Are there questions from the audience? Yuka. Achter je, behind you.
I think that your arguments on not recording the impact of your implementation on your care processes is mute. I think that as an alternative to clinical trials, serious quality improvement project can be made. And that means you measure, you implement, you verify, and you measure again. And I think that you've just lost an opportunity for doing that. I think that we can have, as you outlined, you have several interventions which may have an impact. So the way to do it would be to measure the effect of the package. Take the implementations that you implemented in the last few years, see what it was before, let's say time on mechanical ventilation, level of sedation, I assume you measure it routinely, and have a look. I mean, it's possible. We did something similar a few years ago. We published that, and I think that it's doable. And it's really, I think it's a shame that we lost the opportunity. I mean, you've obviously done a large-scale implementation, and it would have been nice to see the effect on something.
I don't know. I'm to a certain point I agree, but it's so difficult. If I could have shown you perhaps one right here that in the last 3 days our average days spent on the ventilator was reduced by 1 day. I mean, is that our reduction in delirium incidents? Is that the use of NAVA? Is that the early mobilization? I think it's so hard. I mean, what do you learn from that? If our number of days on mechanical ventilation has reduced by 1 day by using such a heterogeneous strategy. I mean, yeah. I mean, you could show it. I mean, we could still show it, but I don't think it gives any relevant information.
I tend to disagree. It depends on how you do your implementation. If you can use what the industry does is control charts over time. You can look at your variation before you start implementation. You create your control limits, and then you implement your interventions, and you look at what happens over time. And of course, it is clear that you can't, if you implement simultaneously multiple interventions, you will have some overlap, but at least you will have an idea on whether something happened. You might even be faced with the fact that maybe something went worse.
Yeah, but then we're going to argue, was that the NAVA? Was that because we started out with prophylactic Haldol, or because we went to a different unit? I mean, can't we just agree upon that this is a strong physiological rationale? What is, except from the economical issue, but what can be wrong from identifying such a severe asynchronies? Or if I think that I do a supported mode and it's a completely rest of the diaphragm, I mean, from a physiological point of view, it's so logical to do that. We're not going to do a trial on arterial blood.
Didn't your staff recognize those dysynchronies without the use of the EIRD? I mean,
no, they didn't. I think that Paolo Navarrete has shown today you can't.
The displays were quite dramatical, showing that you have a problem, even without the diaphragmatic signal.
Yeah, but I think Paolo today showed in this critical care medicine study, even very experienced clinicians can't really identify the problem.
Leo, could there be another downside of it? Could you actually prolong the weaning process if you don't know what to do with NAVA during weaning?
Oh, sure. I'm sure. It's a danger if you don't know what to do. And I'm quite sure in the beginning when we started out with that, it could be that we had prolonged weaning because this was a new mode. Nurses and doctors might be hesitating to do anything with the patient, just saying, oh, he's doing fine. We're not going to touch this patient. And if he would be on pressure support, they might have done a spontaneous breathing trial. So I completely agree. If your training is not good, you have the risk of prolonged days spent on the ventilator. Yeah.
Yes.
Yes, Jukka, I think, talk about the synchrony. There is today a gazillion papers coming out of a synchrony, and everybody sees these little fluctuations in waveforms. What they see is the tip of the iceberg, what you call something like 10% asynchrony today, using a TIL index that was the first one with Laurent Brouchard. That is probably corresponding to, in real life, an 80% asynchrony if you actually look upon, if you want to hit the bullseye on that breath. It is complete garbage, a lot of the stuff that is in the patients. I mean, Leo has right here. You go to the bedside and you look with EDI, you get surprised. I mean, I work with so many different groups and we get the same information everywhere. I don't think we can ignore that, but I totally agree with your point that yes, every time somebody implements something and don't measure it, it is a loss of information. It should be done in a way that it should be evaluated. Yes, I agree with that.
I mean, if you don't measure, you can as well go to the church.
Yeah. Well, that is a little bit what ventilation is about today.
And pray, you mean? Okay, the last question. Okay, Leo, thank you very much. We continue with